Hello, everybody. Welcome. It is Thursday afternoon, and it's another episode of Figuring Out Fertility here with Fertility Matters Canada. I am Carolyn Dubé. I'm the Executive Director with Fertility Matters, and I'm thrilled today to be with Dr. Sony Sierra from TRIO Fertility in Toronto. She is the co-medical director there and also has ties with the University of Toronto. Is that correct?
Mm-hmm.
Mm-hmm. So Dr. Sierra, thank you so much for being here today. We're coming to the end of November, but in October, we really recognized miscarriage and loss awareness month. And we're going to talk a little bit about that today. So thank you. I'll leave it over to you just to give yourself an introduction and we can get going.
Okay, well, first of all, thank you very much for having me. It's my first time on Fertility Matters. Excited to be here and nice to meet you.
Nice to meet you.
And thank you for giving space to this really important topic. October was Pregnancy Loss Awareness Month, and we are always aware in what we do of the risk of miscarriage and the experience of women having miscarriages. But it's nice to sort of have an awareness on social media. And I think in recent weeks and recent months, we've had even more so with some, people who are prominent in social media speaking out about their personal experience. So it's all positive in that it starts the conversation, as does this session. So appreciative of that.
Absolutely. In fact, the conversation is quite timely. Meghan Markle, it was just announced that she experienced a miscarriage in July. And of course, we're all very familiar with Chrissy Teigen being very open about her quite late pregnancy loss a couple of months ago.
Yeah, those were two big names that spoke about it. And I think the important thing that they have brought to light is that it doesn't matter if it's an early loss or a late loss, there is a significant grief reaction that goes along with that warrants, being attended to and being able to find a space to talk about it. And I think those are the commonalities in those two experiences.
Yeah, that's a great point. For those of you who are watching that have experienced a loss or miscarriage, our Figuring Out Fertility session next week is with a reproductive counselor who is going to speak to that topic. So if it's something that's triggering for you, please know that you can tune in next week on Thursday, and we'll be talking about strategies to help you cope. So Dr. Sierra, how common is miscarriage and loss?
So it's actually incredibly common. So one of the things that continues to amaze us is how inefficient we are at making babies. So not only is it difficult to get pregnant to start with, we only have about a 20% chance of conception in any given cycle for young, healthy individuals. But the babies that we see, those precious babies that we get to take home, those are really only the tip of the iceberg. And prior to recognizing a pregnancy with a positive pregnancy test, we know that maybe 50 to 60% of positive pregnancy tests actually fade away and are miscarriages before we see a heartbeat. So it's very common. We estimate somewhere between, depending on particular study, it could be anywhere from 25% of all women experience an early loss up until 40 to 50%, depending on where we define that loss mark.
Wow, that's very common. And in the infertility community, is it more common for women or couples who are experiencing challenges with fertility to experience miscarriage, or is it the same? Do you know that? I'm not sure.
I think it's about the same. Like we don't see that couples who undergo fertility treatment for basic infertility issues have any increased risk of miscarriage. However, those miscarriages have a significant impact. All have an impact, but especially a pregnancy loss after years of infertility is particularly heartbreaking in some cases. But in the infertility world, in our clinics, and especially in my practice, I do see patients with recurrent early pregnancy loss, which isn't as common. Recurrent early losses, we define someone having that issue if they have 2 or more losses. And we think it's maybe 5% of the reproductive population that have 2 or more losses. And we typically see those women and couples in our clinics.
Okay. So let's talk a little bit about recurrent losses. Do we want to start there?
Sure.
Okay.
Sure.
Do you want to, how about we talk about, sometimes we see in our support groups, so we have online support groups, and sometimes we see mostly women talking about having experienced several losses. And I'm wondering, and then they're questioning, is this because I am infertile? Is this because I have an issue here? If someone's tuning in and has been experiencing several losses, what's their first step? Do they continue to go to their family doctor? Like if they haven't moved on to the infertility step yet?
Mm-hmm. That's a great question. And I think there's a lot of sort of uncertainty as to when people should come to us. Before it used to be classically 3 early losses that would warrant a referral to a specialist, whether it's a family doctor sending to an OB-GYN specialist or an OB-GYN sending to an infertility specialist. However, now we tend to see women and couples who have 2 or more losses, especially when age is a consideration, or if there's other reasons, gynecologic complications, and or if there's another problem with infertility or delay to conceive. So typically I would say 2 or more losses should warrant a referral to an reproductive endocrinology and infertility specialist. Okay, great.
Because we do, like I said, we do see that. And I'm wondering at what point do women advocate for that? Because sometimes, I mean, I've actually had conversations with people that I know who have experienced loss after loss after loss and are continuing to see an OB or a family physician, and nothing's happening. And I was curious personally, actually, sort of what are the next steps? So referral or getting yourself in to see a reproductive endocrinologist or a fertility specialist would definitely be helpful.
Yeah, and I think it's especially important for women who are older, because it is also very common as we get older to have more pregnancy losses, right? Due to random genetic error. And so there's a tendency to say, oh, it was just bad luck, try again. But the reality is that it is bad luck and you should try again if you've had 1 loss. But if you've had more than 1 loss, and sequentially even more than that, the more losses you've had, the less likely it's actually due to random bad luck. Therefore, you should come in and get tested. And also with women who are older, if you think about, they're trying to conceive, they get a positive pregnancy test, they wait for a heartbeat, that's 6 to 8 weeks along already. And then if a loss is diagnosed, it might take an additional 1 or 2 weeks to declare itself, several more weeks to manage that loss, and then whatever time involved for healing, which could be 2 to 3 months or more, depending on the emotional experience. And so you're behind 6 months. And if you're thinking about that biological clock ticking in the background, it makes it even more important to be seen quickly and manage things, at least rule out any issues that may be treatable, so that at least you can try again quickly and with peace of mind.
Mm-hmm. Wow, that's very, very helpful information. Thank you for letting us know that. Is there a common denominator? Or what are the reasons, I suppose, that recurrent loss does happen?
Right. So that's a big question. So there's a lot of reasons. So I alluded a little bit to the fact that early loss is part of how we inefficiently reproduce, right? Mm-hmm. So in understanding that, we also understand there's a lot of random genetic error that happens in early reproduction, and accounts for 70 and 90% of those early losses that we have that are prior to a heart being established are due to reasons that chromosomal error has happened. And so that accounts for the majority of those sporadic losses that we see. And in certain populations, you can have it happen in a recurrent basis. For example, women who are older. But when we have ruled out random genetic error, so if it's a young woman who's had 2 losses in a row, that's pretty suspicious, for not being random error. Or if you had been able to collect pregnancy loss tissue after a second miscarriage and had it tested, and we know for sure that's not random error, in those cases, we need to investigate. And sometimes we get historical clues from reviewing patients' history, medical history, gynecologic history, family history. But a full workup for recurrent pregnancy loss does include either asking about or investigating things like structural chromosomal errors, genetics, genetic risk, not random numeric, but actual structural issues, structural factors in the uterus, so things that you can be born with, such as heart-shaped uterus or a septum, or things you can acquire, polyps, fibroids, scar tissue from previous losses or previous D&Cs. That's definitely something we investigate. There's a whole bunch of hormonal factors. So thyroid's important to pay attention to in a history of recurrent pregnancy loss. We look at prolactin levels in certain women and patients. We also need to look at sugar, insulin metabolism, overall markers of health and well-being. I do look at iron levels, and vitamin D levels are also important in this population. In certain cases, we look for autoimmune concerns. So if we understand how embryos attach and implant, it's this huge interplay between vascular factors, autoimmune function, and there are certain autoimmune issues that can lead to problems in this invasion and implantation stage. So we test for certain antibodies around that time frame. The other issues we can test for are infection. So there's newer data available about the uterine microbiome. So looking at not just ruling out bad bacteria in the uterine environment, but also ensuring that there are adequate amounts of good bacteria. So looking at there for answers. And then lastly, I also look at male factor. So not in terms of count and motility for this population, because that's not really an issue if they have no trouble conceiving, but it's more looking in detail sort of at the integrity of the sperm. We look for DNA fragmentation. We're starting to question if sperm aneuploidy is an issue, sort of at a research level.
And for those of people who don't know, sperm aneuploidy is?
It's just having an increased number of sperm that are genetically abnormal, right? And can be linked to other male factor problems.
Okay.
So those are areas that are still sort of not standard of care. But again, in understanding a couple or patients and looking and seeing what their risk factors are, what their family history is, we can sort of fine tune which investigations to expand and look at.
Okay, that's really helpful. That was very thorough, things I hadn't thought about. So thank you. I'm sure that the people that are watching this or that will watch the replay of this will find some information. There may be something you said there that kind of says, oh yes. Now for people who have, is it, if someone's had several pregnancies and live births have resulted, and then, what is the probability of them going on to have recurrent loss or even a loss? And is there something that could have been, do we look at that population differently because we know that they can carry a baby to term, or I'm curious about that.
Yeah, so I think what you're referring to is something we call secondary recurrent early pregnancy loss. So having had a baby and then had a string of miscarriages, and sometimes it's intermittent. So they'll have had a baby and then some miscarriages and then another baby. And then, so sometimes that sort of history will trigger suspicion around specific etiologies or specific risk factors. So I mentioned structural chromosome issues. That means people who carry things like reciprocal translocations in their chromosomal makeup. And what that means is they walk around with a complete set of genetic information. However, in making sperm or eggs, we're passing on only half of our genetic information. So just by chance, and the way reproduction works is you could pass on half that's complete, or you could pass on half that is either missing or has too much. So those couples, those patients will often present with pregnancy that carries to term, no issue, and then an early loss or a later loss, and then another pregnancy. So that's one of the things that we would work up if that history was presenting. Another thing is sometimes with secondary loss, we also question more immunological issues. So something in the first pregnancy triggers an immune response that might have an impact on secondary or subsequent pregnancies. So that's another area that we would look at, looking at acquired antibodies. But how common is it to have that picture? I don't have a statistic. I would still say it's in the range of about 5% or less that present. But it doesn't lessen that emotional impact. It is just as hard, I would say, if you've had a baby and then you have a string of miscarriage. It's still a similar experience.
Absolutely.
And therefore still warrants referral, investigation, and potential management.
Okay, great. Thank you for that. Sorry, I've been asking a lot of questions. I should say, is there anything, do you want to speak about something specific or?
No, I think it's a big topic. It's an important topic. So appreciate the questions.
Great. Okay, I'll keep going. I have a couple of more questions.
Okay.
And if you're watching live, if you're on Zoom, you can put your question in the chat box. If you're on our Facebook Live and you have questions for Dr. Sierra, please put them in the comments. I'm monitoring them on my side, and I'll ask Dr. Sierra as we go along. Okay, so what, if any, lifestyle factors are important when considering recurrent loss?
So that's a really good question too, and it's an important question, and it's an important area that we address because we're in this unique situation where someone's had a miscarriage and then they come see us, so we have an opportunity to offer good sound advice about lifestyle factors. The interesting thing is that there's not a lot of data specifically in recurrent loss, but we can talk about risks for spontaneous miscarriages that come with certain lifestyle factors. So things like coffee is a common question. Should I stop drinking coffee? I've had a miscarriage. The answer is there is an association between caffeine intake and early loss, but typically with a lot of coffee intake. So if we're up to 4 or 5 cups of coffee a day, yes, that can be associated with loss, even in male intake of that level of coffee. So I always say 1 to 2 cups, keeping a caffeine intake to less than 200 milligrams a day. And that's the same for couples who are trying to conceive and or have a history of miscarriage. Smoking, definitely not. Marijuana is common or more commonly reported now. I can't say more commonly used, but just we hear about it more. We don't have any data specifically to say that there is an increased risk with early loss. However, again, if we're talking about smoking and marijuana and wellness, as much as you can maintain healthy choices, healthy lifestyle, it's important. The same thing with sleep. 8 hours a night is important. Other lifestyle factors, ensuring normal diet and exercise linked in with weight. So normal maintenance of a healthy BMI or regular maintenance of a healthy BMI is really important. We definitely see increased recurrent loss with extremes of weight, whether it's overweight or underweight. And there's some pretty good studies to show that obesity itself is an independent risk factor for pregnancy losses that are actually not related to random bad luck. So they've ruled out random bad luck losses, and we still see an association with BMI over 30 and early loss. So that's a really important lifestyle factor. The other things that we have to pay attention to are environmental toxins. So I think we are getting better. BPA was definitely linked to spontaneous miscarriages, spontaneous or recurrent pregnancy loss. But I think that there's been a lot of education. We're more well aware of the role of BPA, and we avoid things like heating plastics and plastic containers as much as we can. Phthalates is another one that, again, can be related to spontaneous loss. It's the additives in lotions that prolongs, lotions and a lot of beauty products that prolong shelf life. So being aware of what you're consuming, how much you're consuming, especially in that time of trying to conceive in early pregnancy, is important.
Wow, that's really important. You see that a lot of times on bottles. Don't use this one, or don't use this one, or consult with your physician prior to using a new product. So that's a really good piece of advice, because I don't think some people, me included, would have actually thought about that, that would be an issue and potentially could have had an impact. Really awesome. Thank you for that.
The important thing is, maintaining as much as you can a healthy lifestyle without having restrictions impact your lifestyle. So do you know what I mean? Like, it's important to have a full life and not constantly think, I can't have this or I can't do that. But as much as you can, just adopt what's a healthy life that you feel good about, controlling factors under your control, so that we can go into the next pregnancy where outcome might not always be under your control. At least you can go into it with peace of mind.
Absolutely. That's great advice, especially during the pandemic. More people are under a lot more stress, probably have a bit more anxiety, just in COVID anxiety. So speaking of anxiety, does stress have an impact on recurrent loss?
So, very common question, and it's a good question, and it's a difficult one to answer. So the way I approach it is, I think that we all have an innate ability to cope with a certain amount of stress. And when we're outside of what we can cope with, when we're outside of that buffer, it starts affecting relationships, it starts affecting our sleep, it starts affecting our regular day-to-day life. And that's when we know we're outside of our buffer, and it may have an impact on things like your experience of early loss. Not that there's a one-to-one association of a certain level of stress and recurrent loss, but I think understanding how you feel and how you're coping and seeking out help when you need it, as you need it, is most important to do. Part of our, in being a recurrent loss program at TRIO, part of our management is having a lot of close and early pregnancy surveillance, a lot of touch points where we can contact patients to tell them their progress, and also they can contact us. And that support is really important. And it's not just important in our clinic. It's been shown sort of across the board in numerous recurrent loss pregnancy studies that being part of a program, having that sort of early supportive care, increases chances to take home a baby. And while we don't understand exactly how that happens, it's likely related to the fact that we are trying to address those issues of stress and offering support. Outside of what we do, making sure sleep is well managed, accessing sort of adjuvant treatments such as massage therapy, acupuncture, naturopathy. All those things are important for addressing stress and can be helpful, but they're sort of on an as-needed, individualized basis recommendations.
Right. Do you find that just in terms of stress management, do you feel that patients connecting with other patients can be helpful? I know that TRIO runs support groups monthly, I think, or pretty regularly. Fertility Matters Canada has online support groups that are free for patients, and they can join and connect with other peers who are in similar situations. Do you find in your practice that patients who have connected with other patients Do you find that that can help manage some of their concerns just by feeling connected to a community?
I think so. I think that's a big part of it. So similarly, being part of a program, but also finding support from people that have had similar experiences. And that's not something, we can offer from a clinical point of view, but definitely beneficial when we think about support groups. And it's also seen, like we alluded to, the social media posts, like just having people talk about it, sharing their experiences. When you look at that Meghan Markle op-ed piece she did for the New York Times, if you look further down, there's an opinion piece that says, you all know someone who's had a miscarriage. And it's a really nice piece that says, everyone it's only 1 degree of separation between you and someone who's had it, and having that sort of a supportive environment where understanding it's not an experience unique to you is definitely a benefit.
Yeah, I would agree. And when we connect with our patients and we get feedback from them, they very commonly say, not only about loss, but also just about their journey in general, that connecting and feeling supported and understood has been incredibly helpful to them throughout their family building journey, no matter where they are. Sorry, say that again.
I just said agreed.
Agreed, yes. Are there any treatment options that can improve a chance of a take-home baby for someone who has been experiencing recurrent loss?
So there's lots of options. So in that workup, of course, if we see something that needs treatment, so if there's an infection or there's a polyp that needs to be removed, we can address it, and that should increase chances to take home a baby. But, in the cases of unexplained, so say we do investigations and we don't find anything wrong, what are the treatment options there? So we do I do give progesterone in the luteal phase and early pregnancy, and that's been shown to be helpful if women have had more than 2 losses, and we see an increased benefit to progesterone with the more number of losses you've had previously. So that's an important part of the treatment that we offer in a conservative. So sometimes the treatment for people who've had unexplained losses is just, being there as soon as they conceive or just before they conceive, using progesterone. And then, like I said, a lot of early close pregnancy support. So following beta levels and then ultrasounds every other week. And just doing that alone does increase chances to take home pregnancy, we think in the range of about 70% or so.
Wow.
So it is beneficial, but there's still a risk of loss. There's still that 30% some odd risk of pregnancy loss. So there are couples who want treatment that will lead to less loss, or perhaps they have issues with fertility, or perhaps they're older, or even, we've proven that despite all of that, they've lost embryos that are genetically abnormal. And then the treatment option for that can include IVF with pre-genetic testing. And that treatment can reduce the risk of pregnancy loss in certain patients who end up with normal embryos. It can reduce the risk of loss to less than 10%.
Wow, that's incredible. Those are very good statistics. So thank you for sharing those with us, because sometimes, I feel that in conversations, again, I get a lot of patient feedback. I'm connecting with a lot of people, and sometimes patients don't know where to go, or they feel that if they've been having recurrent miscarriage, that this is just the way it is, and there's actually nothing that they can do. So that encouragement, or that is encouraging for patients to know that they can carry on their journey with some help.
Right. Yeah, I think women, patients who've had recurrent pregnancy losses, we know that across the board, the prognosis is still really good, right? In 15 years of so practice in this area, there has rarely been cases, or that I can remember, where people had recurrent pregnancy losses that didn't eventually somehow get there, right? It's
Awesome.
different from, you know, an infertility population. In women who've had early losses, they have proven fertility. They are fertile. So sometimes it's just a matter of getting the right embryo, getting that right egg, and they're fine. So it just depends. But overall, prognosis is still very good in this population.
That's awesome. So encouraging. Thank you for that information. I have another question that's come in. Hi, thank you so much for this. I'm interested in multiple miscarriages where the fetus presents with a relatively okay heartbeat at 8 weeks, and then a miscarriage occurs around 10 to 11 weeks. So far, I've been told the plan for the next time is to supplement with progesterone and monitor. Just wondering if Dr. Sierra has any thoughts on these types of miscarriages, or the justification for progesterone supplement, and how one might try to address this before pregnancy without hormonal treatment. I know very specific medical questions can be difficult for you as a physician to address, but you may have some insight there.
A couple of things. One is the fact that the losses are happening a little later. So we talked about that really high time of risk for early losses is prior to when we see a heartbeat. So once we see a heartbeat, pregnancy losses that happen after are usually less common. And the other important thing is that they usually are less likely due to random genetic error. In other words, there's something else potentially going on that causes those losses. So I would ensure that a complete workup has been done and treatable factors have been ruled out. But yeah, I think progesterone is an important part of treatment. And for a long time, we didn't actually have scientific data backing up our use of progesterone. But in the last couple of years, in the UK, there has been some significant efforts being made to pool data from a number of clinics and get really robust, significant findings that have shown, like I said, that with increased number of losses, we see an increased benefit to using progesterone. So it is definitely an important part of treatment, whether, you know, people have a history of recurrent loss and they conceive naturally, or they have a history of recurrent loss and actually conceive with any sort of assisted reproductive techniques. Progesterone is still important.
Great, that's very helpful. I hope that the viewer that's watching that asked that question feels that was very helpful for them. Another question that's come in, just give me a second here to read it. If a patient has experienced multiple births, so I assume multiple live births, but then has experienced multiple miscarriages, can the miscarriages, I assume no tissue would be left over, but can those miscarriages be the reason for additional miscarriages?
So yes, you know, we do see the risk of miscarriage go up with the number of miscarriages you've had, right? So having one pregnancy loss, having 0 pregnancy loss, we have a 35% chance of a miscarriage. Having 2, it's about the same, but having 3, it's increased, et cetera, et cetera. So definitely the number of losses you have increases the chances of further loss. But, you know, is there something about those losses that has put you at risk? Again, should get seen and have investigations done, because yes, sometimes there can be issues related to products of conception left over, maybe changing that uterine microbiome environment. There might be bacteria, especially if you've had instrumentation to remove products of conception in the past. And the same treatment of miscarriages, such as a D&C or surgical management, could also lead to some degree of scarring in the lining. So definitely need to be investigated. And there are certain reasons or certain causes that can be related to prior losses. Definitely.
Thank you for that. So that's all the questions that we've had come in. Is there ever anything that we haven't touched on that you'd like to address? Anything you think we're missing or that's important to talk about?
No, I think we talked about all of the reasons that you could have losses, and sort of the importance of being investigated. I think one of the points that is really important to both investigation and management is really having, if possible, products of conception collected and tested. So again, because a lot of losses happen before you even enter the doors of a fertility clinic or gynecology clinic, that message might not be out there. And I think it's an important one to be. So if you're having your second pregnancy loss, if you are able to be seen and have products of conception collected and tested for genetics, it'll really help in sort of the next steps. So for instance, if you had your second miscarriage and we test the pregnancy loss tissue and we find out that it's genetically abnormal, then we can tell you, rest assured, there's nothing that you could have, would have, should have done differently. That pregnancy was just not meant to be, and your body's quality control is doing what it's supposed to do. And therefore, we don't need to do anything else. Just take time, emotionally heal, and try again when you're ready. Whereas if you have a loss and we collect the tissue and we test it and it ends up being genetically normal, then we know that it's not because of random error that pregnancy didn't continue. And then we need to actually do an investigation. So starting with a history, looking at lifestyle factors, making sure weight is healthy, etc., and then running through tests as needed to rule out anything else that's potentially treatable.
Great.
And that's a really important question. The hard thing is that it's not always easy to get seen and have products collected and tested. There are private companies that are now offering that. So collecting tissue, having it stored at home, having the kit sent to your home, and having your products tested is an option. But I think speaking to your healthcare provider, whether it's your GP or your OB, if you're having a second loss, to see if that can be arranged is really important.
Great. That was my next question. So for people who are watching, that maybe, there might be someone that watches that's currently going through a loss or has done that or has had a loss in the past and is wants to prepare in case that could happen in the future. How would someone go about doing that? So would they connect with their GP? Do they go to an emerge doc? And do they just request that piece? And how open do you know? And I'm sure it's different across the country. How open are physicians to helping with that piece for the patient?
Yeah, I think you start by asking. And there are early pregnancy clinics that are in a lot of the major hospitals. And most times as patients are having pregnancy losses, they can be referred to early pregnancy clinics. And most early pregnancy clinics are set up to be able to offer that. Now, usually they will do it if there's 3 or more losses, but I think if you ask, or if a woman is older going through a loss, it's a reasonable request to at least ask. And then if that doesn't happen, then like I said, there are private companies you can ask them to sort of put you in touch with them. But I think it's on us as fertility specialists to really get the message out there and provide access to those resources. We do at the clinic, but we understand we only see a very small population or percentage of the population that's undergoing
Absolutely. That. Yeah, I agree. Thank you for addressing that. I think that that's very important and it's not talked about, but that's important information for patients to have so that they can advocate again to have this piece of information to help them get closer to that family that they so desire.
Yeah, and in an efficient way instead of having, more losses, because with every loss, it's time, it's emotion, and it's hard on women. So the more quickly we get answers, we can start treatment, the quicker you get.
That's really important. Thank you for that. I think that that's really pertinent information. And if you're watching and need more information on that, you can connect with Fertility Matters, or you can connect directly with Dr. Sierra through the TRIO Facebook page or Instagram. Dr. Sierra, do you have your own Instagram handle that patients can connect with?
I'm not that great. I just
That's okay.
Posting. But I do. It's just at Dr. Sony Sierra.
At Dr. Sony Sierra. Sorry.
Yeah. Okay.
That was a tongue twister for me. So please feel free to connect with us if you have any questions or if you have any additional questions for Dr. Sierra. Please reach out to her through her own Instagram, or TRIO will be able to navigate you to her as well. So Dr. Sierra, thank you so much for your time today. This was very beneficial. It's an incredibly challenging experience. It's heartbreaking. It is frustrating. It is emotional. And I appreciate your ability to shed some light and some hope and some education for everybody that's watching who may have experienced or may be experiencing recurrent loss.
No problem. Thank you again for having me. And thank you again for talking about this important topic.
Yes, thank you. So for everybody that's tuning in, thank you so much for joining us. This was another episode of Figuring Out Fertility. A reminder, we are Fertility Matters Canada, the national patient resource for Canadians who are struggling to build their families. And we are a charity. We are relying on charitable dollars to continue to bring these resources and programs to you. So if you have the means, especially in this time of giving, please consider making donation to Fertility Matters Canada. And that will help us to continue to bring resources to patients from coast to coast. Thank you so much. We'll see you again next week for another episode of Figuring Out Fertility.
Take care.
Bye-bye.
Bye.